Welcome everyone to today's webinar. I am Mackenzie Bean, an Assistant Editor with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Kevin Amar is a neurosurgeon at the Neurological and Spine Institute in Savannah, Georgia, where he has practiced since 2007. Following neurosurgical residency at the University of Alabama at Birmingham, he completed a dual orthopedic and neurosurgical spine fellowship at Cedars-Sinai Medical Center in Los Angeles. He is currently chairman of the Department of Neurosurgery at St. Joseph's Hospital in Savannah. Saul Epstein has over 20 years of experience in ASC administration. He currently is ASC administrator for both Park Creek Surgery Center and Delray Beach Surgery Center in Florida. He is also the president of the Florida Society of Ambulatory Surgery Centers. Jeff Hayes currently serves as Director of Field Training and Product Support for Paradigm Spine. Serving the neurosurgical and orthopedic community for nearly 17 years, Jeff develops and promotes clinical education materials to ensure best practices and optimal clinical outcomes for our patients, surgeons, and facilities. He is currently based in Jacksonville, Florida. Dr. Raymond Golish is a fellowship-trained spinal surgeon, board-certified orthopedic surgeon, and PhD medical device scientist based in Palm Beach, Florida. He is the Chief Quality Officer and Chief of Surgery at Jupiter Medical Center. A leader at the intersection of quality care, spinal surgery, and innovative technology, he is the chairman of the AAOS Biomedical Engineering Committee, a member of its Council on Research and Quality, a member of the NASS Evidence-Based Guidelines Committee, and a consultant to the U.S. Food and Drug Administration. He was a spinal surgery fellow at Stanford University, earned his medical degree and a PhD in engineering at UCLA, and an MBA at Duke. Dr. Golish, I'll now turn the floor over to you.
Great. Thanks so much. Good afternoon, and thanks to everybody for joining us. So I put as my first slide a comment on 1.6 million people. Are you seeing them in your practice? I put this kind of tongue-in-cheek because, as we think all know, lumbar spinal stenosis is one of the most common diagnoses in all of spine. So one of the most common surgical procedures and disease states in all of surgery, all of elective surgery. We know that age-related wear and tear creates problems with the spinal anatomy, both in the front, ventral, and in the back, dorsal, which creates stenosis, just, of course, the medical term for narrowing of a hole. But when the holes through which the nerves run become narrowed, symptoms increase, and this includes not just age-related wear and tear and back pain, but worsening and potentially debilitating, radiating leg pain, tingling, and numbness that builds up over time. The building up over time is important because, being a chronic condition like the so-called boiling frog, patients can cope with their symptoms non-surgically for long periods of time, getting increasingly debilitated, worse symptomatically, until the point where their function is severely impacted. So the question, provocatively, are you seeing them in your practice, is yes, you're seeing them in your ASC, you're seeing them in your clinical practice, or you're just not doing spines. And the question is, how can we best treat these vital and active patients getting increasingly debilitated with this common problem in the outpatient setting? Next slide. So it's critical to highlight that with any kind of surgical pathology, the mainstay of elective treatment should be non-surgical. Of course, in ethical practices, both in the outpatient setting and in the clinic, these patients are treated with non-surgical options, including physical therapy and rehabilitative measures, passage of time. In addition, in the ASC setting, epidural and other spinal injections are administered, which can be helpful, but are morbid procedures all their own and are not perfect treatments. When we talk about the third tier of treatment, surgical options, traditionally surgical options for this common problem sort of dichotomized, and there were really only two choices. The mainstay has been microsurgical decompression. Now, make no mistake, this is an excellent operation, one of the best operations in spinal surgery, one of the best operations in all of surgery. Every ethical and skilled surgeon has cured countless people with this excellent surgical procedure. That said, it's not perfect, and the alternative to spinal decompression alone is important for patients who need further treatment. And the things that make a patient with spinal stenosis a tougher customer who might need additional treatment include the preponderance of back pain, include lots of degenerative disease that makes you think their spine will further degenerate, collapse, and potentially cause recurrent stenosis, no matter how beautifully the operation is done the first time. And they also include the need for stability without making the operated segment too rigid, and therefore without creating the possibility of so-called adjacent segment disease, avoiding the possibility of worsening stenosis at the levels above and below. And the problem with decompression alone, despite it being a good operation, is that the only adjunct to it traditionally was decompression with a fusion. A fusion is a good operation for patients who need it. But for patients in the middle, there has not been an alternative above and beyond decompression that was short of a larger operation involving decompression and fusion. So in essence, surgeons were often left, for patients with severe stenosis, lots of back pain, high risk of recurrence, surgeons were often left with the possibility of undertreatment by decompression alone, and the possibility of overtreatment by decompression with fusion. This significant and large middle part of the patient population is what Coflex was designed to treat and what Coflex solves. Next slide. So as we talk about the middle ground before decompression alone and the alternative to decompression with fusion, there's a very substantial portion of the patient population that is treated with the gold standard operation, a beautifully done microsurgical decompression to free up all the pinched nerves judiciously and excellently, being done all around the country today, right now, but then augmented with a motion-preserving device, the Coflex device, that provides stability, increases longevity, treats undertreated back pain, but without the downside of a rigid fusion involving a larger, more morbid operation, without the downside of a non-motion preserving fusion that increases adjacent segment disease. Next slide. When we talk about the value proposition of Coflex and interlaminar stabilization, it's important to note that with coding clarity, this is one of the few situations where we get the so-called triple win. A benefit to the patient, an excellent opportunity for the surgeon to help patients with a high level of clinical evidence, and then a reasonable opportunity for the outpatient setting, be that hospital and the ambulatory surgery center, to participate in the treatment of patients that traditionally, for larger operations, were hospitalized for protracted periods of time. This is a big sea change within spinal surgery as a whole, within the careers of people on the telephone call today and people on the webinar today. The outpatient spinal surgery has been a revolution. It's gone from patients wondering, spinal surgery is an outpatient, I'm not sure that sounds right, and evolved towards spinal surgery is an outpatient, that'll be okay, to the final place we are today with spinal surgery as an outpatient. That sounds great to me. I don't need to be hospitalized. I do get to go home. This has been really a revolution in patient thinking and is a good opportunity here. And as I let you look through the details of this slide and that opportunity for the ASC setting for surgeons and patients in that triple win, it's important to point out the high degree of clinical evidence available to support the Coflex procedure. In my career as an FDA consultant, as well as a leader in spinal devices, I've had the opportunity to review the totality of the scientific evidence for all spinal and orthopedic devices, Class 3 devices brought onto the market in the 21st century. When we look at all those, the level of evidence behind the Coflex procedure is second to none for all spinal devices, second to none for all spinal surgeries. And that's impactful for patients with a high degree of clinical evidence. Next slide. So I want to pass it on to Jeff Hayes, who's going to tell you some about the anatomical details of the device and talk about lumbar spinal stenosis disease and treatment.
Thank you, Dr. Golish, and thank everybody for joining the webinar today. I'd like to give you a brief overview of lumbar spinal stenosis, as well as introduce a novel treatment option for this debilitating disease. Next slide, please. So what is lumbar spinal stenosis? Well, simply put, LSS is the narrowing of the foramen or openings in the lower area of the spine that results in pressure on the spinal cord or nerve roots. As you can see, comparing the two images on this slide, the left image denotes normal, healthy anatomy. The image on the right, however, clearly depicts narrowing of the central canal and exiting nerve roots. That narrowing can be the result of several causes, including thickening of the ligaments, enlargement of the facet joints, or disc-related issues. As a result, LSS is a common cause of leg and back pain. Next slide, please. Typical symptoms of LSS include pain and/or numbness, weakness, tingling in the legs brought on by walking and/or standing, and is often only relieved by sitting, leaning forward, or lying down. In many cases, leg pain is also associated with low back pain. The most common symptom of LSS is known as intermittent neurogenic claudication. Next slide, please. Lumbar spinal stenosis is a degenerative process. This degeneration can be related to several factors such as age, activities, injury, or other predispositions. It usually occurs over time as abnormal forces in the spine causes changes in the disc, ligaments, and facets. As each segment degenerates, the spine may become more unstable. In some cases, the spinal segment may begin to slip forward due to this degeneration. This is known as a spondylolisthesis. In general, cases of mild, moderate, or severe stenosis may not be treated with conservative care effectively and may require surgical intervention. Next slide, please. Historically, the need for surgical intervention basically boiled down to two choices: decompression or decompression with fusion. However, with the FDA approval of Coflex interlaminar stabilization in 2012, a novel third treatment modality has emerged. So what is Coflex interlaminar stabilization? Coflex is the first and only non-fusion stabilization device for lumbar spinal stenosis patients implanted after direct surgical decompression. Coflex treats a significant population, has established coding and reimbursement, and can be performed in any site of service. Next slide, please. As mentioned before, up until relatively recently, the decision for surgical intervention comprised, again, of two choices. Looking at the infographic, you can clearly surmise that patients with more mild disease would more likely receive a simple decompression, while more severe disease may require a decompression with fusion. Coflex, however, offers a new option for treating LSS patients who may need a little more than a decompression alone, but may not require the full extent of a fusion. And again, Coflex is available in any setting of care. Next slide, please. The Coflex device is intended to be implanted between the lamina of two adjoining spinal segments. It is for use in the lumbar spine only, from the L1 to L5 levels. When implanted in a way consistent with its FDA labeling, It has been clinically proven to support the decompression, preserve motion, address leg and back pain, maintain foraminal height, and preserve normal motion at the operative and adjacent levels. As you can see from the images, after a direct decompression, Coflex loads on the laminar bone and not on the spinous processes. Unlike interspinous indirect decompression devices, which only act to block extension, Coflex's unique design allows for both flexion and extension. Next slide, please. The surgical procedure for Coflex follows a less invasive, familiar approach. The surgeon first identifies the operative levels, and using the natural anatomical angles of the spinal processes, carefully creates a parallel channel for the Coflex device. A direct decompression is performed, allowing the surgeon to address multiple patient symptoms. Once the surgeon has completed the decompression, trials are then introduced to assess the appropriate size device for the patient's anatomy. The Coflex device is then implanted between the laminas of the adjoining operative segments. Next slide, please. As mentioned previously, the Coflex device is implanted post-direct decompression. As you can see in the example to the upper left, the decompression can be quite robust with direct exposure of the neural structures. It is also possible to decompress up to 50% of the medial facets bilaterally. The takeaway is this: starting at 6 weeks post-op and followed out to 5 years, Coflex consistently proved to be comparable to fusion in overall improvement in VAS leg functional outcome scores. Next slide, please. Because Coflex loads in the interlaminar space, the surgeon's decompression can be preserved. Typically, if a surgeon is concerned with instability, the most common course of action or option was to fuse that segment. Coflex is the only treatment option that allows a surgeon to stabilize a decompression without fusion. If you compare the images on the left and right of the slide, you can clearly see that the patient has received a direct decompression. As indicated by the blue arrow, note the decompressive channel between the two images. Further, the green oval demonstrates where foraminal height is comparatively maintained. And lastly, the yellow arrow clearly shows how the facet has been offloaded and maintained. Next slide, please. As mentioned before, back pain is a common symptom associated with lumbar spinal stenosis. Many surgeons set expectations with their patients regarding surgical treatment and the positive mitigation of back pain. Based on the 5-year evidence, it is believed that the deep interlaminar positioning of the Coflex device allows for facet offloading. This offloading effect protects the segment, all while preserving motion. The graph demonstrates the overall improvement in VAS back pain, and as you can see, Coflex patients demonstrated a 70% improvement in back pain immediately post-op, which was sustained through 5 years, again, all while preserving motion. Next slide, please. Finally, the evidence demonstrates that Coflex maintained both foraminal and posterior annular height at 5 years, clearly proving that Coflex is durable and sustainable treatment option for lumbar spinal stenosis patients. In addition, as a primary indicator to measure operative success, ODI pain and functional outcome scores are often used. At the 3-month postoperative point, as well as out to 5 years, Coflex patients demonstrated greater sustained improvement in overall ODI, indicating that stabilizing with the Coflex interlaminar device is a safe, effective, and durable treatment for your stenosis patients. Next slide, please. With that, it's my pleasure to hand it over to Dr. Kevin Amar to discuss his clinical experiences with Coflex. Dr. Amar?
Thank you, Jeff. Next slide, please. And we can go on to the next one, please. Okay, well, thank you for the opportunity to speak about Coflex. So how did I first find out about this? Well, it was about 2 years ago when a visiting surgeon gave a seminar in Savannah when it was first brought to my attention. And at that time, I really thought about it as a modest technical extrapolation from Medtronic's X-Stop, with likely similar deficiencies of durable results and limited insurance acceptance. How I now think of Coflex, however, is really a durable solution for 1 or 2 level lumbar stenosis, and also a simple but efficacious option that warrants consideration for certain cases of grade 1 spondylolisthesis with radiculopathy. What I know now that I didn't know then about Coflex is that it is very easy to use. There are modest technical nuances, and I think I've gotten better at using it as I've used it more. But it is very easy to use, and I've had excellent results thus far, and my patients are very happy with it. Next slide. So determining patients for Coflex and which ones are best treated in ASC versus the hospital, or inpatient versus outpatient. I'd like you to focus on the last sentence at the bottom here. Really, I think about this the same way I think about patients that I treat with laminectomy alone. So those with medical comorbidities that may necessitate an overnight observation, might have a poor social network at home, or 2-level cases where I might need to leave a drain. Those are the patients that I would generally do inpatient hospital. In regards to outpatient hospital, it really comes down to those with a hospital preference. And then for the ASC, that leaves us with everybody else. Next slide, please. So I began incorporating this into my surgical center and practice with a simple single-level case to make sure I felt good about moving forward. And we did feel good about it and have moved forward with great success with it. It did really bring a new population of patients that previously may not have been considered for the surgery center setting, and specifically, perhaps those that may have been considered for a fusion, for example, a grade 1 degenerative spondylolisthesis, that I typically may not have considered for the surgery center, now might be a candidate for the Coflex on an outpatient basis at our ASC. So for those who are considering bringing Coflex into their ASC, I would suggest starting simple, build appropriate expectations with the patient preoperatively, consider paraspinal musculature, local anesthetics that you might use for other outpatient procedures, and then always be cognizant of the possibility of a hematoma being a problem, and consider use of polymerized gel foam or even placing a temporary drain if you feel this is indicated. Next slide, please. So far, I've treated 27 patients with the Coflex. 2 of these were in 2016. And so 25 have really been done in 2017 since it was approved by Medicare. And of those, I've removed 1 due to some recurrent radicular symptoms, which I feel now in retrospect was in part probably due to technical inadequacies in my part in putting it in. But overall, we've had good luck thus far. Next slide, please. So to move on to some cases, this first one is a 69-year-old male. It's a fairly large gentleman, no history of any prior surgery, with stenosis as seen on the MRI to the right in the sagittal and axial plane, which I would qualify as moderate. He had had a year of progressive bilateral lower extremity pain that was consistently increased with standing and walking and consistently improved with sitting. He tried an epidural injection with transient benefit. Next slide, please. He underwent a single-level decompression in Coflex in March of this year. He was last seen in August and had resolved lower extremity pain. Did have some modest low back pain for which he was sent to physical therapy, but overall was happy with the procedure. If you focus on the right lower picture with the arrows, what I wanted to point out with the blue arrows without the red outline is the presence of osteophytes, cephalad and caudal to the L4-5 level, which were not initially recognized on the MRI, but in retrospect, I think probably not only contributed to the development of the stenosis, but also, should a decompression alone have been undertaken, may have predisposed him to the development of some glacial instability over the long run without the use of the Coflex. So I think this example shows kind of the potential benefit of the Coflex as a insurance policy on your decompression to help mitigate against that possibility. Next slide, please.
Dr. Amar, this is Dr. Golish. Can I interject on your last case for just a moment?
Sure.
This is a beautiful case. Can we go back 2 slides, please? This is a beautiful case, and I appreciate you leading with it. Just for the non-surgeons on the line, the bottom image shows a classic stenosis example, and on your left-hand side, the lateral recess is particularly stenotic, meaning what used to be a nice round canal has turned into a trefoil-shaped canal, like Napoleon's hat. The black ligament on the back side is squashed down. The epidural fat is compressed into a relatively small space, and you see there's a fair amount of arthritis in the facet joints. As Dr. Amar has rightly pointed out, this is a good opportunity for a Coflex because I'll speculate, Dr. Amar, you've successfully done decompressions on lots of patients with this profile. But as you're pointing out, next slide, the amount of spondylosis, meaning plain old arthritis and degeneration, can contribute to instability, as you've emphasized. It also contributes to the possibility of additional spondylosis, additional breakdown throughout the course of this patient's very long life. The foramen at that level in the future would be at risk to recurrent stenosis as this process of breakdown. So a gentle motion preserving stabilization, I think, is well indicated in this patient for the reasons you described. And what I love about this case is that these patients can do well with decompression alone, but the additional amount of stabilization you've chosen with a non-fusion motion preserving, I think, will preserve the longevity of the nice work you've done with the microsurgery.
Thank you.
Thanks for allowing me to interject.
Absolutely, and feel free to do on any of these. Thank you. So this is the second case, 70-year-old female now, progressive symptoms of back and bilateral lower extremity symptoms in an L5 distribution over a year that consistently improved with sitting, who's already tried physical therapies, epidurals, ultimately facet injections and radiofrequency ablation without lasting efficacy. She was found to have a grade 1 degenerative spondylolisthesis at the L4-5 level, which did not move on flexion versus extension. Next slide, please. She also underwent a single level decompression at L4-5 and insertion of the Coflex, which was done in February. Follow-up was last in April, and she told me at that time she felt that it had helped her about 90%. I know she was pretty happy because we ended up treating her husband about 3 months later with the Coflex also, so I thought that was pretty good testimony about it. Next slide, please. This is an example of a 2-level case in a 44-year-old gentleman. This is an unfortunate gentleman. Used to work for Georgia Power and actually lost both arms in an electrical accident. And since that time, became an avid runner, which I think may have contributed to some of this degenerative issue. No history of any prior surgery, and he presented to me with about 6 months of severe bilateral lower extremity pain. Really not back pain, but just lower extremity pain that was consistently worse with standing, walking, or running, and very limiting to him. He'd already exhausted conservative efforts, and the stenosis is seen on the slides to the right. Next slide, please. He underwent a 2-level procedure, which is seen in these slides. And what I wanted to show here was that, number one, there's not really a up or down side to the Coflex is one thing that I've learned, and that it really can be applied with equal efficacy in either direction. One thing that is really critical when you're doing a 2-level case that I've learned too is that you do need to be thoughtful about which one you do first in an effort not to preclude optimal placement of the second device, because it is critical that the second device sits at a depth that's adequate to really serve its biomechanical purpose. And that's really what I wanted to show on this. So next slide, please. And this is actually my last slide. This is a 52-year-old female that had progressive bilateral L4 symptoms. It's really pretty minimal back pain, actually. It was mainly L4 distribution radicular symptoms that were worse with standing and walking. No history of any prior surgery. Had been through conservative efforts with physical therapy and epidural injections, and was found to have a non-dynamic grade 1 spondylolisthesis at L4-5. You also see on the AP X-ray on the upper right hand of the screen that she does have a very mild coronal deformity. Very minimal amount of rotation is present. And then on the MRI, she does have some early degenerative changes at L3-4. So this is a patient that in the past, I almost certainly would have advocated for treating with a TLIF, fusion at the decompression and fusion at the 4-5 level. Now, in her particular case, I was very concerned about doing this because of predisposing her to advanced degeneration at the L3-4 level. And next slide, please. And so we actually did get her approved. She was actually a commercial insurance patient, but we actually were able to do a peer-to-peer, speak to them, and move forward with the Coflex at 4-5, which has been successful for her thus far with follow-up at 5 months. So I thought that's the one commercial case that we've done, and we were able to get successful clearance of it after explaining the rationale for it, and it's worked out pretty well so far. And with that, I believe I will turn it over to Saul.
Thank you, Dr. Emmer. Well, next slide, please. I've been in the ASC business for going on 20 years now. This is my third surgical center that I'm involved with, Park Creek Surgery Center and Delray Beach Surgery Center, both in South Florida, not too far from one another. And we have been doing spine surgery here at our centers for a number of years now, with Coflex fairly new to us. And as mentioned, I'm president currently of the Florida Society of Ambulatory Surgery Centers, where there's about 400 and some centers here in the state of Florida. I think we're the third largest in terms of number of ASCs in the United States. California and Texas are there as well. As I mentioned, Coflex was introduced to my center back in 2015, actually by one of the surgeons that has been bringing his spine cases to us for a number of years, and asked if we would consider adopting the technology for his patients. And we looked into it and decided it made sense economically for us, which I can describe as we move forward. And we've expanded the utilization and surgery use through 2017, essentially due to reimbursement increase from the Medicare program with the procedure code. Next slide, please. So in 2015, the spine surgeon requested that the Coflex be done here at the ASC. We looked into the economic sensibility of doing it and determined that for a particular payer type that this physician was contemplating using it, it made a good sense. We decided to look at it from a sort of a clinical use perspective in the OR, determined it's really a simple add-on to doing a basic decompression, and we've been doing decompressions here for, it's got to be 6 or 7 years now. We were one of the very first surgical centers in South Florida to start doing what I call real spine surgery, not just doing neurostimulator implants and so on that a lot of centers were doing at the time and still doing now. We progressed up through doing decompressions in 2 and 3 level ACDS and so on. So we do some pretty complicated, complex work here at the surgical center. It does not require additional post-op services, which is important to us since we have a very sophisticated post-op program for our patients that have the more complicated procedures. It's minimally invasive. It's an alternative fusion as described in the prior slides. It's not a complex surgery overall, and it required an additional small investment for a small instrument set since we had already developed the infrastructure of doing spine cases. I mentioned in 2017, the CPT coding changes came into effect. There was an actual CPT code that got assigned to this procedure. In the past, there really wasn't one to use. And so due to those changes, the case volume has increased. It's provided an opportunity for recruiting additional Coflex cases and surgeons to practice at the ASC, where in the past they had not been coming. And the existing medical staff member doing Coflex Medicare case at the hospital, not knowing could done at the ASC, started bringing over here to the ASC because of the economics. Next slide, please. So after the surgeon showed interest in the procedure, we did the following. We identified a case that would make some sense. We did, as I mentioned, the economic analysis, mentioned the 2017 CPT code got reimbursable by Medicare in our environment. It is a bundled rate. Medicare does not reimburse separately for the device. It's a combined reimbursement rate that incorporates the facility fee as well as implant cost. It's possibly reimbursed by private carriers, as mentioned by Dr. Marr. In that instance, the commercial carrier authorized the treatment. It is not an easy process, I can tell you, to get a commercial carrier. They many times consider it to be considered experimental in their view. And so it's troublesome and time-consuming to get these things approved. So it's been predominantly either a Medicare case for us or a letter of protection case with PI cases that we do a few of, or it's been paid by workers' compensation here in the state of Florida. ASCs contract proactively prior to doing a case. I assume the hospitals do the same thing. So we would by no means take a case, assuming reimbursement is here, and then on the back end try to get coverage. It's generally tried in the beginning to do that, and as I say, it's difficult to make that happen on the commercial side. Of Medicare, there have been no issues in terms of retroactive denials. There's a clinical evaluation of the patient confirming that it's appropriate for the ASC. There are certain patients for BMI or comorbidities and so on that we believe, the medical director believes, are not appropriate for the ASC environment, notwithstanding the procedure would make sense, but for patient safety reasons, we ask the surgeon to bring the case to the hospital, and it's on a patient-by-patient basis. There's a coordination with the paramedic representative for the instrumentation and coverage on the procedure day. And then we look at the post-case economic evaluation of the case. As I mentioned, the ones we've done so far, we've had no denials by the carriers in terms of denying reimbursement after submitting the claim. Next slide, please. So the advantage of having Coflex at our ASC. It's a new type of spine procedure. It expands our repertoire of various procedures we can provide. It's minimally invasive, as I mentioned. It is an alternative to fusion, as been discussed in the other slides. It serves the new stenosis patient population very well, as described. And it has a potential new insurance base that wasn't previously available in prior to 2017 because of the new CPT code and the adoption by the Medicare program for reimbursement. The OR time, which is important to us because that's what we have for our utilization, is similar to a standard decompression. It doesn't take that much longer to do this additional technique for the patient. The instrumentation, as I mentioned earlier, we have accumulated a lot of things over the years, and there is a very small addition that's necessary, small tray, no additional major investment necessary for making the procedure work at the center. So it's economically profitable for us. Recruitment opportunity is inherent. We talk to spine surgeons and ask them to come to our center. There are some surgeons that still believe the ASC is not appropriate for spine work. This is helping us to overcome that hesitation, and once a surgeon comes to us, finds the patients are happy, the surgeon's happy, then potentially additional procedures can be done as well. So it's a marketing advantage to us to be able to provide this service to get new doctors to come in, which results in new cases and more volumes that are profitable for our surgical center. Next slide, please. So it's a smart fit for the ASCs on a business level. It's a less invasive procedure for the patient. It's a recruitment tool for surgeons, and it's economically viable. It makes us money at the surgery center. The coinsurance applied to us is lower than it would be done in a hospital. If you saw the prior slide, I believe there was like a $14,000 Medicare reimbursement on a one level. Here it's about $10,000. The patient pays a 20% coinsurance if they don't have a supplemental to Medicare. That 20% of $14,000 is more than 20% of $10,000. So from the patient's out-of-pocket perspective, it's less expensive. I go through a whole lot of reasons why ASCs are far better than hospitals, in our view, for these kinds of procedures on lots of levels. It's an easy procedure to adopt when trying to grow your spine business in an ASC. It's a simple, minimally invasive lumbar spine procedure. As I mentioned, less instrumentation, lower time, cost compared to posterior lumbar fusion. There's no comparison. Doing a posterior lumbar fusion is a fairly complicated procedure. It is probably the most expensive procedure that we do here when we do a posterior lumbar fusion. There is substantial home care that's necessary that we provide. It takes a long time in the operating room and takes a lot of instrumentation. So it's not even a comparative in terms from a business perspective on this procedure for the appropriate patient than a posterior fusion. And we now have reimbursement clarity with the 2017 reimbursement pathway in the ASC setting from the Medicare program and the CPT code coming from the American Medical Association. So in summary, it's a great way to get started in differentiating your surgical center and growing your spine business from doing a basic discectomy and laminectomy, which a lot of centers are now doing, and getting to the next level, perhaps, of getting more complicated posterior fusions or ALIFs or ACDFs or whatever, of getting to that next step. This is kind of an interim process, it appears to me. Next slide, please. So in summary, you have a disease state solution at site of service, an opportunity to differentiate your practice and the surgical center. And patients, as I understand it from our doctors that are doing this, describe, as Dr. Marr described, the patients are very happy with the outcomes from the procedure.
Great. Saul, this is Ray Golish. Thanks for that nice presentation. I appreciate you taking a look, hard look and clear-eyed look at the economics and the reality around them. They're favorable. But I did want to get back to your more philosophical point within your long 20-year career and your history of being one of the leaders in doing, as you put it, real spine surgery in the outpatient setting. What is driving this from the patient point of view? And the reason I bring this up is a direct complement to what I said about the evolution of outpatient surgery in my practice. The reason I bring this up is because a lot has been said about the move to outpatient surgery, spinal surgery in particular. I mean, whatever site of service, so the hospital or the ASC, some people have opined that it's driven by payers. Some people have opined that it's driven by surgeons. Some people have thought that it's driven by ASC administrators. But what part of that faces the patient, and what's been your experience of how the patient views outpatient surgery and the advantages they perceive as time has gone on?
Well, what I find the patients, and it's generally not just for spine surgery, right, but for all of the surgeries that we do here, it's a much friendlier environment. It's not as hostile, it's not as aseptic as the hospital. They walk in they come from the parking lot, they walk in, they don't go through the hospital system. The infection rate here obviously are very, very low, if non-existent. The hospitals, there's infection rate and all sorts of other issues. So I think over time, people have become accustomed to doing more and more things outpatient. And the spine is just another interruption going to the next step. And because more and more spine surgeons, and if I go back 10 years ago, the number of spine surgeons in my market were very few. There are far more spine surgeons now for lots of different reasons. And so there's more, I think, emphasis on providing spine in the outpatient environment than there had been. And as I mentioned, a lot of the surgeons 8 years ago, when we started doing this, just said, no, I don't do that kind of thing in an outpatient. That's a hospital procedure. And over time, they have changed their view radically, and now really very much prefer coming to the facility, and they talk to their patients and explain why it's better for them economically and clinically, and that gets them over the hurdle. If there is one, and they come, and they've been very happy. The satisfaction rate is extremely high.
Yeah, thanks for that thought and follow-up. This is Ray Golish again, and I just wanted to add that in my experience, having done spinal surgery in the outpatient setting at several sites of Surface Hospital, outpatient ASC as well, I think Coflex fits kind of a unique niche in the overall evolution you've just described of the surgical sites of service. And by that, I mean a decompression can be done well for those patients, again, worse back pain due to facet disease, worse overall spondylosis and arthritis, putting them at higher risk for recurrence and recurrent stenosis and recurrent symptoms down the line, regardless of how beautifully the index surgery is done. And then those people needing stabilization of some kind without the rigidity of a fusion, but also in the outpatient setting without the morbidity of a fusion. Because unlike being a friendly environment, if you get an oversized, overly aggressive operation as an outpatient, there can be consequences to that. And I personally have done minimally invasive fusions in many different ways. Dr. Ameyer, I strongly suspect, has done minimally invasive fusions in many different ways. They're good procedures, but the overall impact and the surgical profile of a beautifully done microsurgical decompression is fairly low. Adding a Coflex to that adds very little in terms of the overall surgical magnitude. There's been a renaissance in mini midline microsurgery as a less invasive surgical procedure, and staying close to the midline, avoiding wide exposures, avoiding multiple incisions, and really being able to do a beautiful microsurgery with stabilization through a mini midline approach is something that, as you put it, is in the middle, not too morbid, but stabilizing, and it's a nice, unique, I think, look on what can be done in the outpatient setting. Next slide.
Hi, Dr. Golish. This is Mackenzie Bean. Thank you so much for that great input and discussion. Right now, I want to go ahead and begin our question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So it looks like we have a lot of great questions rolling in. The first one is, what types of training does Paradigm Spine offer for surgeons?
So this is Ray Golish. I'd like to hear Jeff's thoughts on that as well. I can tell you about the training I received, which was as much as I wanted, which is good to know, meaning there are laboratory cadaver opportunities available. There are consultants and MD surgeon medical advisors available for first case and other cases, just in terms of the overall approach and philosophy. In addition to that, the company has I think, very rich set of options for intraoperative support, not just the typical rep, but above and beyond that, especially in the early stages of adoption. But it's also important to point out, not just in terms of training, but in terms of back office support for authorization and pre-authorization. It's a robust program. Jeff, maybe you could unpack that a little bit more.
Thank you, Dr. Golish, and that everything that you mentioned is absolutely correct. Initially, when a surgeon is trained, that can be done by several different methods, peer-to-peer training, concierge training online through webinar. There's an ongoing training sessions. They can go online and go through a series of training modules in addition to their peer-to-peer or concierge training. Again, as Dr. Golish pointed out, there are interoperative sessions where we bring in a technical support specialist that can answer those questions for as many cases as the surgeon asks for, or may be needed to train both the surgeon, the rep, and the staff.
Great. Well, thank you both for that insight. The next question is, are you keeping these patients overnight, 23-hour stay? If so, what are the risks and complications that would result in the patient being transferred?
This is Ray Golish. Dr. Ameyer, you have some thoughts on that you'd like to offer?
Sure. This is Kevin Ameyer here. We're making that decision generally, preoperatively for the ASC setting. We are set up to watch people overnight if we need to for some reason. However, I've never had to do that for anything that would have been unforeseen. Now, in regards to the other set of the population of patients where we make that decision to keep them overnight, that is a preoperative decision that, so yeah, I would say that there's not going to be something, I have not experienced something intraoperatively or in the perioperative setting, for example, uncontrolled pain or something else that would necessitate an unforeseen overnight stay. The one thing that I personally am focused most on about the need perioperatively for any type of stay is really for a drain, placement of a drain. And, again, for a single level issue, I really think about it just like for the laminectomy patients. And that's how I really think is the best way to think about when you're making that decision.
Yeah, this is Saul. In the state of Florida, there is no 23-hour stay. The state of Florida requires patients to be out of my door by midnight and can come back at 6 o'clock in the morning. And so all the cases we've done here since beginning of time obviously can't stay 23 hours. And generally, these cases are done in the morning. They take a couple hours, and then the patients are here for a few hours upon discharge. So in all the years we've been doing these things, not just with Coflex, but all the procedures, we've not had those kind of complications and so on. So in Florida, it's unique, I guess. In other parts of the United States, there's a 24-hour care, but not here.
Great. Thank you both for elaborating on that. Saul, let me actually ask you another question. How do you communicate to your surgeons and then coordinate that Coflex can be done at your ASC?
Well, what we've done here is notified them via email. I've sent some articles to them so they understand the clinical application. Some didn't even know it existed, and so it's an educational process. And then describe about the economics of it, because a number of them didn't realize, as I mentioned earlier, that it can be done at the surgical center and economically for the Medicare patient. So it's an educational process.
Great. Well, thank you so much, Saul. Looks like the next question coming in is, how do you decide a patient is right for the ASC setting versus the hospital?
Yes, so this is Ray Golish. Can you advance to the next slide, please? Just as a follow-up, next slide. A follow-up to what Saul said, and next slide again. In response to your question, it might be nice to leave this up on the screen. I'm interested in Dr. Amar's answer. Yeah, thank you. Dr. Amar's answer to the question as well. For me, it's the patient with all the appropriate medical readiness for outpatient surgery, all the appropriate psychosocial support systems, meaning supportive family and loved ones at home. I think for the people who are told that they need those resources, most everybody has them with some exceptions. But I think overall, getting back to both Saul and Dr. Amar's points about the evolution of outpatient spinal surgery, much of it has to do with setting expectations. So if the patient expects that this is going to be how their case is handled and they're confident that they have planned, not just mentally and psychologically, but in terms of the resources, mostly these individuals are delighted to go home. In terms of the need for stays, I just haven't found that necessary personally. And when I started doing outpatient spinal surgery, I presumed I'd have bounce backs, and the rate at which that happens is astonishingly low. It's nearly zero in my experience in hands. And so I think that many people are candidates. There'll be some obvious exceptions, including medical morbidities, but it's also important to pick the right candidate for an outpatient Coflex. And I think that many people who have lumbar spinal stenosis without extremely severe medical comorbidity fall into that category. And this is true across payer classes. We saw in Dr. Amar's case presentations a variety of ages, by presumption a variety of payer classes. The company Paradigm Spine does have pretty rich and exuberant resources for helping to aid that back office process and also the ASC process. So I think the choices are broad, but it does depend on comfort level. The critical thing is really setting expectations with the patient so that they know how their day is going to go. Helps a lot.
Yes, and that's
Dr. Amar, you have
Kevin
something?
Yeah, I really totally agree with all of that. I think so much of it is really, you know, as a surgeon, you really want to do obviously what's safest for your patient. And so I think a lot of surgeons have this concern about multiple procedures on an outpatient basis, and before putting their toe in the water, so to speak, you know, there's a little anxiety about that. But my experience has just been that the more I've done there, the more I've seen that it is really a win-win. It is really something that the patients have been very comfortable with, and as a result, it's built up the repertoire of cases that I will do there. And I will say that this is on the much smaller side of that spectrum of cases. So absolutely, I think that anybody who is a safe medical candidate is somebody who definitely warrants consideration.
Great. Well, it looks like we have time for one more question, and I'm going to steer it to you, Dr. Amar. What part of Coflex really enticed you to adopt the technology?
There are so many aspects of this, and we've barely kind of scratched the surface in today's presentation, really. But I'll tell you, it's to have a durable solution that can replace the option of fusion within the context of multiple spinal pathologies is just a really unique asset for a spine surgeon as he sits in clinic and scratches his head looking at films and trying to come up with an optimal strategy. And so I kind of fell in love with the idea back with X-Stop initially for certain things, and then there was interlaminar fusion that kind of seemed like it might be a nice option. But because of the motion preservation and durable aspect of this, it has really found a unique place in my practice as I consider options. So to me, that's the value that it's added.
Absolutely. Well, that is all the time that we have for today. I want to thank Paradigm Spine, Jeff, Dr. Amar, Saul, and Dr. Golish for the excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you.
Thank you.
Thank you.